The subcommittee will come to order. The chair recognizes himself for 5 minutes for an opening statement. Today's hearing on the Independent Payment Advisory Board comes at a crucial time. It is a crucial time for health reform in general. It has been almost 16 months since the passage of President Obama's massive overhaul of the health care system. And as the multitudes of provisions in the law go into effect, we're beginning to get an idea of how our health care system would look under PPACA. The fundamental concept underlying the administration's approach to health reform is that the government or a group of government-appointed experts knows better than patients and their doctors which health care services are valuable. It is also a critical time for the Medicare program in particular. A quick look at a few numbers will remind us of the importance and timeliness of today's hearing. 10,000 seniors become eligible for Medicare every day. And according to the program's own actuaries, the program faces costs not covered by the Medicare tax of more than $30 trillion over the next 75 years. This staggering amount of money is more than double the current national debt. One of the most worrisome provisions in PPACA, and a provision that highlights the administration's fundamental approach to health reform, is the creation of the Independent Payment Advisory Board, or IPAB. The IPAB embodies what is objectionable in the President's health care system overhaul and how the administration's approach to health reform is fundamentally different from the Republican reform proposal. President Obama's health reform legislation was pushed through Congress without meaningful bipartisan debate. In like fashion, the recommendations of IPAB will be pushed through Congress with very little time for discussion or for the development of realistic alternatives to these recommendations that will then become law. The IPAB is likely to profoundly influence the future of Medicare and even the health care system in general. In fact, the panel of 15 experts that will make up the board will arguably have more influence over health care than any person, group of people, organization, or government agency has ever had, more than patients, physicians, professional organizations, MedPAC, CMS, or even Congress. However, we need to be clear about one thing. This isn't about death panels. The intent of creating IPAB was not to kill seniors. But Democrats do believe that the best way to cut Medicare costs is to give an unaccountable board the power to limit treatment options. We disagree. We believe the solution to fighting cost is to give patients more power, more control, and more choices. Why should anyone, especially a government-appointed expert, second-guess patients and doctors? It is encouraging that there is widespread opposition to the IPAB. Physician groups, hospitals, consumer groups, patient advocacy groups, and others have all voiced their concern over the board. There is even bipartisan opposition in Congress. This is not surprising, since the decisions of the board will become law by a fast-track process that will bypass the usual legislative procedures, in effect superseding the customary jurisdiction of committees like this one. As Representative Pete Stark was recently quoted as saying when asked about IPAB, quote, "Why have legislators?" End quote. The time for substantial Medicare reform is now, and the decisions about how to achieve the necessary reform are crucial and fundamental to the future of the program. The Democrats would leave these decisions to 15 unelected, unaccountable government appointees. We believe that current and future Medicare beneficiaries know better. I want to thank the witnesses for agreeing to participate in this important hearing. I look forward to hearing their testimony. And at this point, the chair recognizes the ranking member of the subcommittee, Mr. Pallone, for 5 minutes for his opening statement.
Thank you, Mr. Chairman, and thank you for holding this very important hearing. I am very strongly opposed to the Independent Payment Advisory Board, or IPAB, created under the Affordable Care Act. I've never supported it, and I would certainly be in favor of abolishing it. However, I do not see IPAB as a significant factor in the Affordable Care Act. As you know, I'm one of the strongest advocates for the Affordable Care Act. For many reasons, the Affordable Care Act has finally set our health care system on a path to reform. It was the most significant improvement to Medicare passed in years and will reduce costs to Medicare through a number of broad efforts, most notably by reforming the way in which doctors deliver care, incentivizing a focus on efficiency and value rather than just the number of services performed. Furthermore, it's important to note that the Affordable Care Act reduced projected Medicare spending growth to historically low levels. Over the past decade, Medicare cost growth per beneficiary was 7.8%. The most recent trustees report projects that over the next 10 years, that growth rate will be just less than 3%. Now, it's becoming increasingly clear that the Republicans will use IPAB as just another way to oppose and deface the Affordable Care Act. But this issue, from my perspective, should be the furthest thing from partisan. It is an issue that I believe all legislators from all political backgrounds should take concern. It's about the legislative and executive branches. This is about congressional prerogatives being limited. We should absolutely not, under any circumstances, cede legislative power to the executive branch. This is simply not what our founding fathers wanted or intended. IPAB, like other independent commissions, encroaches upon our legislative authority. Indeed, I'm opposed to independent commissions or outside groups playing a legislative role other than on a recommendatory basis. It's not the job of an independent commission to get involved in congressional matters, in this instance, health care policy for Medicare beneficiaries. We've had the counsel of MedPAC for a long time, but MedPAC is just that. It's counsel. Nothing MedPAC recommends is automatic. When Congress agrees, it enacts those recommendations. When Congress disagrees, we ignore those recommendations. This is how the process should work. This is how the process should continue. Unfortunately, the debate over IPAB reminds me of the base realignment and closure, or BRAC, process. IPAB is just another BRAC, only the healthcare version. In fact, during discussion over the Affordable Care Act, it was mentioned by the administration and others that they were using BRAC as an example. I strongly believe that BRAC is a monumental failure. I voted against every BRAC in my 23 years in Congress. I've seen them run up costs and waste money. And the worst part is, as an elected official who was sent to Congress by my constituents to represent their best interests, that I become powerless to stop things like the BRAC. I certainly tried. I fought the closure of Fort Monmouth, New Jersey, with everything that I had in more ways than I can count. But it wasn't enough because, like IPAB, the BRAC took away all legislative authority and prerogative, and to this day I fight to minimize its effects on my constituents. Mr. Chairman, as I said again, this is not about IPAB or its relation to Medicare. It's about a growing imperialistic presidency. I've been here for 23 years. Whether it was the first George Bush, or it was President Clinton, or it was the second George Bush, or now President Obama, the presidency continues to try to take over the prerogatives of Congress. We have to stop it. We have to reverse it. We can't be a part of an effort to let that continue. Just because decisions are tough doesn't mean Congress shouldn't make them. I believe this committee and this Congress has the know-how to make the tough choices that are still needed to improve our healthcare system. And frankly, I've told the President and everybody in the executive branch, I actually like dealing with MedPAC and his recommendations. I like having hearings in this subcommittee where we review the MedPAC recommendations. And most of the time we adopt them. So the idea that somehow we don't want to make the tough choices, we're not capable of making the tough choices, that's simply not true. That's why we're elected. That's why people continue to elect me, in my opinion. So instead, let's build on the Affordable Care Act's reforms and expand efforts to contain the growth in future health care costs. We can do it. We don't need IPAB. I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the Vice Chair of the subcommittee, Dr. Burgess, for 5 minutes for opening statement.
I thank the Chairman for the recognition. I want to welcome our Senator from Texas, Senator Cornyn, and my fellow OB-GYN, Dr. Rowe, for welcoming them to the committee and being here today. This health care law that was signed 15 months ago contains countless policies that will essentially disrupt the practice of medicine. Along with the many excesses and constrictions in the law, the Independent Payment Advisory Board represents the worst of both. I'm a doctor, member of Congress. I'm also someone in my 60s who is soon to be Medicare age, and I am distressed by what I see happening with the Independent Payment Advisory Board. It's not accountable to any constituency. It only exists to cut provider payments to fit a mathematically created target. Given that private insurers use Medicare as a benchmark for their own payment changes, the IPAB could have a far-reaching implication beyond Medicare for our nation's providers. The board exponentially and inappropriately expands the power of the executive branch, giving an unaccountable panel of 15 individuals the authority to make changes in the Medicare program. It takes the authority away from Congress. Congress has no say in the board's reports, yet their recommendations essentially hold the power of legislation. And yeah, this board's appointed with the consent of the Senate, but not necessarily, because 9 of these board members could be recess appointments. 9 of these board members would constitute a majority, therefore completely bypassing the legislative branch. Now, for patients, these bureaucrats will be able to cut payments so low that it will block care to seniors. It does change the fundamental nature of the relationship of the federal government and those people who are cared for by insurance provided by the federal government. Now we'll be able to tell you who gets care, where the care is given, when it's given. But the fundamental change is now we'll be able to tell you when you've had enough. The board is not a solution in search of a problem. Medicare's unfunded liabilities are enormous. That's why Republicans want to be able to keep Medicare for future generations by lowering the cost to the federal government by providing better choices. Let me at this point yield to another doctor on the committee, Dr. Phil Gingrey.
Mr. Chairman, thank you. I thank the gentleman for yielding. I've got 3 posters I would like to share with my committee members and with the witnesses. This first poster, President Obama's chief medical officer, and this is a quote: "Most people who have serious pain do not need advanced methods. They just need the morphine and the counseling that have been available for centuries," end quote. Again, President Obama's chief medical officer, and I quote, "The decision is not whether or not we will ration care. The decision is whether we will ration with our eyes open." And the last slide, again, from President Obama's chief Medicare officer: "I cannot believe that the individual health care consumer can enforce through choice the proper configurations of a system as massive and complex as health care. That is for leaders to do." If anyone has any questions as to why members of Congress are opposed to what has been deemed a denial of care board, as you just heard, I would simply suggest you read carefully the words of the head of CMS, Dr. Donald Berwick, and it's no surprise that he will remain interim head. You might even want to refer to him as Don Corleone. And I thank you for the time, and I would now like to yield to my physician colleague from Louisiana, Dr. Bill Cassidy.
Thank you for yielding. I'm a doctor who for the last 20 years has worked in a hospital for the uninsured. And one of the reasons I ran for office is that well-meaning politicians would have well-sounding laws which would make the lines grow longer at my hospital for the uninsured. I have to say, with Obamacare, it's like deja vu all over again. Medicare is going bankrupt. Anticipating this, Obamacare has a provision of 15 appointed bureaucrats who have the ability to, almost in an unfettered fashion, decrease payment. Now, we say, Republicans, some Democrats, that this can decrease access. Defenders say, oh no, decreasing payment is not rationing. I ask those defenders to join me at my hospital for the uninsured, and I will show you the reality. So although I look forward to Secretary Sebelius' testimony, I feel like I've heard it before. A benign bureaucracy paternalistically looking after the interest of the individual while controlling global health care costs. It would be amusing if it were not so frightening. There is a better way, and the better way is to give the power to the patient, not to the bureaucrat. This is not where Obamacare is, but it is where I hope we arrive. Thank you. I yield back.
Chair thanks the gentleman and now recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes for opening statement.
Thank you very much, Mr. Chairman. There was an attack on Dr. Berwick. He was invited once to appear before our committee and was canceled out by the committee itself. Perhaps we ought to give him the opportunity to respond to some of these statements that have been made about his past writings. I regret to observe that this hearing today is very partisan and very hypocritical. It is partisan because this is another battle in the war waged since January by the Republicans to tear down the Affordable Care Act. When the Republicans passed their repeal bill through the House in January, we were promised that a Republican replacement would be right behind it. But we're now in July, and we have seen absolutely no sign of any Republican idea for addressing our nation's problems in health care. Skyrocketing costs, 50 million Americans without insurance, and uneven quality of care. This is an exercise in hypocrisy because of the utter fallacy of the pious arguments made on the issue of Medicare and costs. I've been around long enough to remember when doctors said, we didn't need any government program. We take care of poor people because that's our obligation. And now we're told we can't find a doctor because they're not paid enough. They don't feel it's their obligation to take care of the poor unless they're paid adequately. I understand that, but let's skip the piety about it. The main Republican attack on the Affordable Care Act is that we cannot afford it. Too much coverage, not enough cost reduction, they say. They ignore the CBO's estimates. They ignore the testimony from hundreds of economists and doctors and experts of all stripes. Republicans just assert it doesn't control costs. And then they attack the new law for comprehensive approach it takes to controlling costs. And they do it the old-fashioned way, through fear. Dr. Burgess has called IPAB Armageddon. Dr. Gingrich compared the Republican plan for Medicare unfavorably to throwing grandma off a cliff, but said that IPAB is worse than that because grandma could possibly survive the fall from a cliff, but cannot survive IPAB. Well, I have some concerns about some aspects of IPAB, but I don't agree with the premise that we need IPAB to make Congress do its job. No one should think that the hyperbole of IPAB's Republican critics, rationing, death panels, faceless bureaucrats, pulling a plug on grandma, represents reality. It is a fact that IPAB is prohibited from rationing. It is also a fact that the savings CBO expects from IPAB over the next 10 years amounts to just $2 billion, less than 10% of what Republicans proposed to cut from Medicare, even before they would end the program in 2022 and replace it with their voucher plan. But the heart of the matter is Medicare and its future. What is the Republican plan for controlling costs in Medicare? Simple. End Medicare as we know it. The Republican plan shifts all of the burden for health care costs onto seniors, people with disabilities, onto the states. It will double costs for new enrollees in 2022 by $6,000 per person, according to CBO. For people with disabilities, including people in nursing homes, Medicaid cuts come almost immediately in 2013, meaning that people won't be able to pay for nursing home care or the home-based care that will keep them out of a nursing home in the first place. Republicans are seeking to end Medicare's guaranteed benefits, leaving seniors and people with disabilities on their own in the insurance market. They want to cut the program by $20 trillion over the next few decades. Fears about IPAB are hypothetical at this point and always leave alternatives to the Congress. The harm to Medicare from the Republican plan, if enacted, would be a certainty. With respect to IPAB, Mr. Chairman, Congress has the final say over Medicare policy. And if Congress has the final say over all IPAB recommendations, which will pass through this committee, I hope one day to return to the chairmanship of this committee, and if I do, I will certainly exercise this committee's oversight duties over IPAB thoroughly. I'm sure that Mr. Upton will do the same. So I think it's time we set aside efforts to repeal the Affordable Care Act, focus on real problems for American families and what they're facing today, and stop this constant attack on anything that tries to do something about the problems that the American families face, especially those who cannot buy insurance, who cannot afford insurance, who cannot pay their doctors adequately so they can be seen, and we just forget about them. We already have over 50 million uninsured. Let's don't add to the burden by taking away Medicare and Medicaid from those for whom they rely on those programs. Yield back.
Chair, thanks the gentleman. That concludes the opening statements for the members. I want to thank the witnesses for agreeing to appear before the committee today. We have 4 panels today, and your written testimony will be entered into the official record. We ask that you summarize your opening statements in 5 minutes. The first panel, and in order presentation, I will introduce them. First, the Honorable George Miller, who represents the 7th Congressional District of California. Second, the Honorable John Cornyn, Senator from the state of Texas. The Honorable David Rowe represents 1st Congressional District of Tennessee, and I believe we have the Honorable Allison Schwartz representing the 13th Congressional District of Pennsylvania coming. Congressman Miller, you may begin.
Thank you very much, Mr. Chairman and Ranking Member Pallone, for the opportunity to testify before the committee today. I came to Congress in 1975, and since that time I've been involved in the debate over national health reform proposals. Throughout these debates, lawmakers have struggled with how to control the cost without harming care. Unfortunately, Congress chose to kick the can down the road for a very long time. Without action, health care costs have continued their endless rise, well in excess of inflation. As everyone here well knows, the costs have grown to unsustainable levels for families, for businesses, and for taxpayers. In the past decade, health care spending has increased an average of 6.8% a year and is expected to rise from 18% of GDP to 34% of GDP in 2040. At the same time, employer-provided insurance has fallen, and out-of-pocket premiums have skyrocketed for employees. The opportunity to reform finally changed with the Affordable Care Act. For the first time, Congress put in place specific identifiable measures to make Medicare and our health care system more efficient. We need to give these innovations an opportunity to work. These innovations include stronger tools to combat fraud and abuse in Medicaid and Medicare, tools that already started to save billions of dollars, to better coordinate the care through accountable care organizations, incentives to reduce hospital readmissions and reward the delivery of high-quality and efficient care, and improve patient safety through the Partnership for Patients initiative. These reforms were included based on what was worked on in the past and what was likely to work in the future. These cost savings ideas are beginning to work. We did not make these decisions lightly. The debate was robust. But in the end, the majority agreed to give these ideas a chance. Our goal was to make Medicare stronger for our seniors and sustainable for future generations, so we wouldn't have to go down the road of rationing or turning Medicare into a voucher program. If Congress begins to roll back these reforms, then we will not see the efficiencies, we will not see the innovations that experts agree will stabilize our health care system. One of these ideas is the Independent Payment Advisory Board. This board serves as a backstop to ensure that our federal health programs operate efficiently and effectively for both seniors and for the taxpayers. Before Affordable Care Act, Congress and other stakeholders had an unremarkable track record of controlling cost. 535 members of Congress cannot be doctors, although it looks like an awful lot of them are. I wonder where that doctor shortage was coming from. 535 members are not capable of knowing the best science and the best practices for every medical treatment, and 535 members of Congress are subject to unrelenting lobbying by special interests that have a financial stake, in many cases a financial conflict of interest in many of the decisions that they make, but not necessarily the best information for the health of our seniors in mind. With these reasons, many experts have recommended the creation of an independent board on health experts to make the system improvement recommendations. And as you know, Congress has often used independent boards to help complex issues such as MedPAC or the BRAC. Without BRAC, Frank, I love you, but the fact is those bases would have never been closed, and we would have been lugging the cost around for generations. The Independent Advisory Board will not usurp the Congress. It will not be unaccountable. It will not be unfettered. It simply acts as a backstop in the case government spending exceeds the benchmarks. Both CBO and Medicare trustees tell us that because of the Affordable Care Act reforms, they don't expect the mandatory actions of the panel to be triggered in the immediate future. The President will nominate the doctors, health experts, consumers, and to the board to examine all of the data and evidence and best practices and efficiencies in health care spending. The Senate will consider and approve each nominee. The IPAB will make all the recommendations to the Congress. The Congress can approve, disapprove, or modify each recommendation. Sounds like a heavy role for Congress. In other words, Congress retains the role in health care, but in an improved and more efficient fashion. Ideally, IPAB recommendations could also be a driver for innovation, not only for the public sector, but for the private sector. Under the law, the Independent Payment Advisory Board guarantees a doctor-patient relationship. Doctors will retain full authority to recommend the treatments that they think are best for their patients. The law prohibits the recommendations that would ration care, change premiums, or reduce Medicare benefits. In conclusion, I testify here today as someone who deeply cares about the delivery of health care to the citizens of the United States. Everyone agrees that our nation's health care costs must come under control. With 76 million baby boomers just beginning to rely on Medicare, the time is now to push for innovative reforms that can help us contain the cost of the Medicare program. The Independent Payment Advisory Board is about strengthening the Medicare program. Without the innovation and evidence-based decision-making, Medicare will be put in jeopardy, and the forces calling to end Medicare will gain the upper hand because of uncontrollable costs. The American people have firmly rejected the Republican plan to end Medicare, to voucherize Medicare. What they do support is accessible and affordable health care, and the only way we can guarantee that for future generations is by using the best science, the best medicine, the best evidence, and the best practices available for all of our citizens. We really have no alternative. Without these innovations, our current system is unsustainable for the nation's families, the nation's businesses, and the nation's taxpayer. And I strongly support IPAB and would oppose any efforts by Congress to undermine it. And thank you so very much for allowing me to testify.
Chair thanks you, gentlemen. Senator Cornyn, you may begin your testimony.
Chairman Pitts, Ranking Member Pallone, and members of the committee, thanks for giving me the opportunity to testify here today regarding the Independent Payment Advisory Board created by the Patient Protection and Affordable Care Act. And unfortunately, this is a product that came from the Senate, not from the House. I'm sorry about that. But of course, the goal of IPAB is one we all share, as Congressman Miller just articulated. We have to find some way to control the costs in Medicare. Medicare trustees have warned Congress that the program will be insolvent in 2024, which is 5 years earlier than previously predicted. They noted that Medicare's unfunded liabilities, the gap between Medicare's future cost benefits and future taxes and premiums it expects to collect, are more than $24 trillion and growing. The Medicare trustees have now issued a Medicare warning every year since 2006, in which they've alerted Congress that more than 45% of Medicare's funding will come from general revenues. The nonpartisan Congressional Budget Office issued a warning of its own in June in its 2011 long-term budget outlook. CBO projects that if current law remains in place, spending on the major mandatory health care programs alone will account for approximately 6% of our gross domestic product today to 9% in 2035 and would continue to increase thereafter. So, as we all know, something has to be done about the unsustainable growth and the cost of the Medicare program. We all agree on that much. Like many Americans and many members of this committee, though, I do not believe that IPAB is the right answer. Everyone here knows how IPAB is supposed to function, but here are my specific concerns. First, I'm concerned that the only tool in the IPAB toolbox will be cutting payments to providers. And we are already seeing how government price controls are restricting access to care. On one hand, saying you're covered by a government program. On the other hand, saying because of restrictive payments to providers, you're good luck finding a doctor who will see you at that price. The American Medical Association estimates that 1 of 3 primary care doctors limit the number of Medicare patients they see. As Dr. Burgess will confirm, in our state of Texas, 42% of physicians are considering opting out of Medicare completely due to low reimbursement rates. Although there's some concern recently about the rhetoric surrounding IPAB, continuously cutting reimbursement to Medicare providers will prevent access to care for Medicare beneficiaries. Secondly, I'm concerned that IPAB's enormous power will grow at the expense of Congress and the people's elected representatives. In fact, as you probably know, and no doubt do know, there is litigation challenging this delegation of legislative authority to this unelected body currently pending. Why Congress would voluntarily undermine its own authority in this area is really beyond me. We are the ones who are elected, we are the ones who are accountable to the voters, and we are the ones who should be making those decisions. Congress created the Medicare program in 1965, and it should be Congress that is held accountable to the seniors who use Medicare as their health care system. But as you know, IPAB has a different approach. Seniors subjected to IPAB recommendations cannot challenge the recommendations in court or remove members of the board. There is no accountability. The only way a member of the board can be removed is by the president for neglect of duty or malfeasance in office. My concerns should be familiar to many of you because these are the same concerns I'm hearing from you and from my constituents, and which I suspect you're hearing from your constituents as well. Scott and White Healthcare in Temple, Texas recently wrote me in support of the bill on the Senate side that I'm sponsoring, the repealing IPAB. They write, Scott and White Healthcare is supportive of initiatives to identify fraud and waste in the healthcare system and to incentivize high-value healthcare in this country. But we have concerns and questions about the process that will be used by IPAB to implement cost savings in Medicare. On June the 24th, 2011, over 270 different organizations from the Pennsylvania Medical Society to the New Jersey Academy of Ophthalmology wrote members of Congress regarding their concerns, saying that not only will IPAB severely limit Medicare beneficiaries' access to care, but also increase health care costs that are shifted onto the private sector. And we are all very familiar with the cost shifting that goes on when the government reimburses at a lower rate, and those with private insurance or private pay have to pick up the slack. They also cited concerns about IPAB's lack of accountability and inability to improve the quality of care in the Medicare program. I want to thank the chairman and the ranking member and this committee for being skeptical of the IPAB from the beginning and for supporting repeal now. Of course, this is not a partisan issue. This is not part of an effort to repeal the health care bill. This is a narrowly targeted piece of legislation designed to deal with this particular provision, which I think deserves and does have bipartisan support. In January 2010, 72 House Democrats joined Republicans asking then Speaker Pelosi to take IPAB out of the health care bill. On Monday, Congressman Pallone was quoted as he was here today saying he didn't support IPAB and certainly would be in favor of abolishing it. Congressman Rowe, his bill enjoys bipartisan support for the legislation in this House, and I hope some of my Democratic colleagues in the Senate will join me in our effort to repeal this particular provision in the health care bill. As we repeal the IPAB, we've got to look at a better way to achieve our bipartisan goal of controlling health care costs in the Medicare program. One model, I believe, that has worked pretty darn well is the Medicare prescription drug program, which has come in under budget by about 40% by providing transparency, competition for quality and service, which has used market forces to discipline costs. The prescription drug program has achieved these results, as I say, by injecting competition and choice into the system. Many other programs at the state level and in the private sector have also cut costs without sacrificing quality or access to care, goals that we all share, and Congress should continue to take a look at those as well. In conclusion, Mr. Chairman, let me just say that Medicare beneficiaries have paid their hard-earned money into Medicare for years, and it should be these same beneficiaries, their families and providers, who determine the health care that is right for them. Thanks for allowing me to testify here today, and I'm happy to respond to any questions you might have.
Chair, thanks, gentlemen. And now,
Mr. Chairman, could I ask unanimous consent that the letters that Senator Cornyn referenced from the Scott and White Clinic and New Jersey Medical Association be made part of the record today?
Okay, could we see those, and then we'll act on that if we
Absolutely.
get copies. Thank you. Congressman Rowe, you're recognized for 5 minutes.
Thank you, Chairman Pitts and Ranking Member Pallone and members of the subcommittee. Thank you for inviting me here to testify today, and I applaud the subcommittee's effort to shine a light on the danger posed to seniors by the Independent Payment Advisory Board, better known as IPAB. I have practiced medicine for the past 31 years, not been in Congress. This is only my second term, and I'm an OBGYN doctor, and I found out delivering your own voters worked out pretty well for me. So, but I firmly in my core believe that health care decisions should be made between physicians, the patients, and their families, not by a board appointed by the President or anybody else, Republican or Democrat. Created as part of the Accountable Care Act that went into effect last year, the IPAB is charged with developing proposals to reduce the per capita rate of growth in Medicare spending. Certainly something has got to be done to ensure that this important program remains available not only for current retirees, but for the next generation as well. The Medicare trustees recently projected that the Medicare Trust Fund will go bankrupt in 2024, and it's been stated the Congressional Budget Office says that the fund will exhaust even sooner in 2020. We already know what President Obama's plan to save Medicare is the $500 billion in cuts to the program and the IPAB. The cuts speak for themselves, but the American people deserve to hear the truth about the IPAB as little more than a roadmap to potentially rationing care. Now, some say that the Accountable Care Act expressly prohibits rationing, raising revenues or beneficiary premiums, increasing cost sharing, or other restrictions on benefits. This is highly misleading, as nothing in law prohibits cutting payments to physicians. Already, Medicare pays physicians between 85 and 90 cents on the actual cost of the care, which has made it more difficult for beneficiaries to access the needed care. If reimbursements continue to fall even further, it could very well become economically impossible for physicians to see Medicare patients. With millions of baby boomers becoming eligible for Medicare, IPAB cuts couldn't come at a worse time. The IPAB could adversely impact the quality of patient care. For example, look no further than Britain's National Institute for Health and Clinical Excellence, or NICE. Decisions are based on cost, not quality or outcomes for an individual patient. Decisions regarding patient care shouldn't be made by a panel of 15 unelected bureaucrats who haven't examined the specifics of an individual's unique case. Medicine is not a one-size-fits-all discipline. What is effective for treating one patient may be harmful for another. By centralizing medical care decision-making, the IPAB would put a Washington bureaucrat squarely between patients and the care recommended by their doctor. In addition to degrading access to and quality of care, IPAB has two significant structural problems. It's both unaccountable and unworkable. The board is empowered to make recommendations regarding Medicare without any input from Congress. Don't just take my word for it. The former OMB director, Peter Orszag, called the IPAB the single biggest yielding of power to an independent entity since the creation of the Federal Reserve. Even after the IPAB makes its recommendations, the hands of the Congress are still somewhat tied. The proposal will be considered under fast-track procedures, and without 3/5 vote of the Senate, Congress can only modify the types of cuts, not the size. And if Congress fails to act on the board's recommendations, they automatically go into effect. This isn't government by the people. It's instead government by the bureaucrats. Questions have also been raised regarding IPAB's ability to function as it's designed. In reference to IPAB, the CMS Chief Actuary, Richard Foster, wrote in the April 2010 memo that limiting the cost growth per beneficiary to a level below medical price inflation alone would represent an exceedingly difficult challenge. The CBO, on the other hand, projects no savings resulting from IPAB over the next 10 years. In both cases, these expert analysis suggests that IPAB will not yield the results promised by its proponents. Further, the legislators who created the IPAB made it clear that they want this board to impact more than just Medicare. The Accountable Care Act requires the IPAB to make recommendations about how to restrain private sector health care cost growth as well. While these recommendations do not automatically go into effect, they will no doubt serve to encourage private insurance companies to cut provider payments. Ultimately, cuts to provider insurance payments will result in even less access for Medicare beneficiaries because most providers shift costs onto private insurance to make up for Medicare losses. So everyone loses under this scenario. While it seems that there is little that our two parties can agree on in the current environment, both sides have acknowledged that the IPAB is a terrible idea. That's why my bill to repeal IPAB, the Medical Care Decisions Accountability Act, has more than 160-plus bipartisan co-sponsors, with all but one physician in the U.S. Congress has signed on. The American Medical Association has endorsed my legislation, as did a broad coalition of more than 270 healthcare organizations. Even former Democratic leader Dick Gephardt called the IPAB for the IPAB's repeal. Mr. Chairman, it's time that we begin the fact-based conversation about reforming Medicare without the demagoguery that has marked recent months. I can't think of a better place to start than a bipartisan effort to repeal IPAB. Let me finish with a couple of things. Ask yourself two things or two problems. Does this bill increase access and quality of care for seniors? And number two, how much oversight and power has Congress given up? And let me just give you a brief example. If you're a family practitioner and you're seeing Medicare patients and you want to continue to do that, and let's say your practice grosses $300,000 this year, which is probably what a family practice would do. About $150,000 of that, 50%, if you run a very efficient practice, is overhead. If you cut, the current SGR growth cuts are recommended to be about 30% at the end of this year. That family practitioner who's making a very comfortable living at $150,000 his or her costs stay at $150,000, but their income will be cut to $50,000. And how does that increase access? If this IPAB basically can do that, how does that help our seniors? I very much appreciate the bipartisan support for this, and I thank you for having me here today.
Chair thanks the gentleman, and now recognizes Congresswoman Schwartz for 5 minutes for her opening statement.
Thank you, Chairman Pitts and Ranking Member Pallone, Mr. Waxman, and members of the committee for the opportunity to testify this morning. First, let me say I have been and continue to be a very strong supporter of the Affordable Care Act because it will extend access to affordable, meaningful health coverage to all Americans, strengthen Medicare, and contain costs for American families, businesses, and government. The potential for savings is significant. The Centers for Medicare and Medicaid Services, CMS, Office of Actuary, estimates that over the course of the first 10 years, the Affordable Care Act will save Medicare more than $400 billion by attacking fraud and abuse, reducing overpayments to insurance companies, reducing medical errors and unnecessary duplication of services, increasing access to cost-effective primary care services, and improving care coordination across healthcare settings, and transitioning to payment systems that reward value. CBO estimates that the law will reduce the deficit by more than $1 trillion over the next 20 years. And that's just the beginning. Healthcare reform has the potential to fundamentally transform the healthcare delivery and payment systems by creating a variety of models for improved delivery of care by incentivizing high quality, greater efficiency, and better outcomes. Successful implementation will ensure that seniors get the right care at the right time at a lower cost to taxpayers. My decision to support repeal of the Independent Payment Advisory Board reflects my confidence in the many cost containment measures in the law. Despite Republican claims, IPAB is not a death panel, nor is it a rationing board. That's merely scare tactics. IPAB is simply the wrong approach to achieving the right goal. We all agree that the rate of growth in Medicare spending must be contained and that current Medicare payment systems are flawed and need to be reformed. But we cannot conceal fundamental flaws in our healthcare system by simply cutting reimbursements to hospitals or physicians, or even worse, ending Medicare as we know it, as the Republicans have proposed. The Republican plan to convert Medicare into a voucher program means that seniors will no longer have access to guaranteed set of health benefits, and according to the CBO, the resulting premiums and coinsurance will increase out-of-pocket costs more than $6,000 per senior per year and increase as health care costs rise. This is neither better quality care nor genuine cost savings. It is merely shifting the burden of increased costs to our seniors. Congress must accept its responsibility for legislating sound health policy for Medicare beneficiaries, including reforms to the payment systems. Turning over this responsibility, whether to insurance companies as proposed by the Republicans or to an unaccountable board, undermines our ability to represent the needs of seniors and the disabled and to ensure access to care. Repealing IPAB while preserving the essential health reforms in the Affordable Care Act enables providers to focus on innovations that will achieve cost savings by incentivizing efficient, high-quality health care. If we do not, IPAB is structured in such a way that the board may be forced to impose cuts on a narrow sector of the healthcare system, ignoring the need for broader changes. Arbitrary cuts on spending absent fundamental reforms to underlying cost drivers simply shift the cost burden. Thus, IPAB has the potential to stifle implementation of the promising innovations that would address these cost drivers just as they're beginning to take shape. The Obama administration is already implementing healthcare reforms to reduce the rate of growth in healthcare spending by holding providers accountable for reduced costs through more coordinated care, the adoption of health information technology, improved quality, and better outcomes. Accountable care organizations, which create incentives for healthcare providers to work together to lower costs while meeting quality standards and putting patients first, could save up to $750 billion over the next 10 years. The Center for Medicare and Medicaid Innovation, established under the health care reform law, is advancing innovations such as the patient-centered medical home, healthcare innovation zones, and other innovative delivery models with the potential to achieve even more significant additional savings. The Center's recently launched Partnership for Patients initiative will save costs by bringing together hospitals, physicians, and patients to dramatically reduce hospital-acquired conditions and hospital readmissions. This program alone is expected to generate savings up to $35 billion. These are reforms that we should build on to achieve greater cost efficiencies without risking access or quality. It is our job to identify the cost-efficient, cost-saving innovations that ensure that are implemented broadly and successfully across the country. There are tough choices ahead as we work to contain the rate of growth in costs in health care. We should eliminate IPAB, reject the Republicans' efforts to dismantle Medicare, and focus on reshaping payment and delivery systems to reward coordination, efficiency, and value to achieve these cost savings. And in so doing, we will meet our obligation both to seniors and to taxpayers. And I thank you for the opportunity.
Chair thanks the gentlelady. Chair thanks the witnesses of our first panel. Very informative. Appreciate the bipartisan nature of it. And we'll dismiss the first panel at this time and call
Mr. Chairman, did we rule on my unanimous consent request?
have we sent it? Have we sent? Yeah. If the senator can give us the documents, then we'll rule on it. Can you make sure we get that? Not yet. Can you get them? We'll act on it later. The second panel consists of a single witness. The Honorable Kathleen Sebelius is the United States Secretary of Health and Human Services. We welcome the Secretary to the hearing. Madam Secretary, your written testimony will be made part of the official record. Welcome. And we ask that you summarize your statement in 5 minutes and then be available after 5 minutes for questions. Could you hear me? I'm sorry. We've had some problems with our mics. Okay. Your written testimony will be made part of the official record. We ask that you summarize your opening statement in 5 minutes. So welcome, Madam Secretary. You may begin your testimony.
Well, thank you, Chairman Pitts and Ranking Member Pallone and members of the committee. I appreciate the opportunity to come today to discuss how the Affordable Care Act is strengthening Medicare for seniors today and tomorrow. My written testimony does provide more detail, but I want to highlight some of the steps we're taking as part of the health care law to fill the gaps in Medicare coverage, to improve care, and make the program more sustainable for the future, while preserving the guarantees for seniors and those with disabilities. When Medicare became law in 1965, it served as a national promise that seniors wouldn't go broke because of a hospital bill. In 2006, Medicare added coverage for prescription drugs, which make up a growing share of beneficiaries' health care costs. But we know that too many seniors still struggle to afford their medications, and that's why the Affordable Care Act moved to assist the seniors falling into the donut hole with a one-time $250 check in 2010, and this year starts a 50% discount for the approximately 4 million beneficiaries who now will get some assistance with purchase of brand-name drugs. By 2020, that gap will be closed completely. We also know that too many seniors were going without the preventive care that can help prevent an illness before they occur, in some cases because of expensive copays. And that shouldn't happen. So beginning this year, the law allows Medicare beneficiaries to receive recommended preventive services like screenings for colon or breast cancer, as well as an annual wellness visit without paying a copay or deductible. It's the right thing to do, and it's a smart thing to do because it helps physicians catch small health problems before they turn into big ones. The law is also helping to improve the quality and safety of care for people with Medicare. We know that there are model hospitals across the country that have adopted best practices to dramatically increase the quality of care. In fact, for almost every major common medical error, we have examples of health systems that have significantly reduced or even eliminated them altogether. There's no reason why all Medicare beneficiaries shouldn't enjoy that same high quality of care wherever they receive it. And that's why the Affordable Care Act provides unprecedented support to help those best practices spread. In March, we launched the Partnership for Patients, an historic partnership with employers, unions, hospital leaders, physicians, nurses, pharmacists, and patient advocates to reduce harm and error in our nation's hospital. Last week, we announced that more than 2,000 hospitals have already signed up and are taking critical steps to improve care. They're aimed at two goals: reducing preventable readmissions and reducing hospital-acquired conditions. Under the law, we've also established the first of its kind Medicare-Medicaid Coordination Office, working with states to improve care for those beneficiaries who are enrolled both in Medicare and Medicaid and often receive fragmented or duplicative care as a result. Through the new Medicare and Medicaid Innovation Center created by the law, we're testing a wide range of additional models for increasing the quality of care, from strategies of helping seniors manage their chronic conditions to new models in which hospitals and doctors who keep their patients healthy and out of the hospital can share in the cost savings they create. Together, these reforms are beginning to dramatically strengthen Medicare today for seniors and Americans with disabilities. We also have the responsibility to preserve the promise of Medicare for future generations, and we can't do that if costs continue to rise unchecked. Because doing care the right way often costs less than doing it the wrong way, many of the law's reforms to improve care also reduce Medicare costs. For example, the Partnership for Patients alone is estimated to save Medicare as much as $50 billion over the next 10 years by reducing errors and unnecessary care. But the law doesn't stop there. It contains important new tools to stamp out waste, fraud, and abuse. And in fiscal year 2010, as we're beginning to build this new system, our anti-fraud efforts returned a record $4 billion to taxpayers. And the new tools will help us build on that progress. The Medicare trustees estimate that these reforms in the Affordable Care Act have already extended the solvency of the trust fund until 2024. Without the reforms, the trust fund would have been insolvent 5 years from now. But when it comes to Medicare's future, we can't take any chances. And that's why the law also creates the Independent Payment Advisory Board, or IPAB, a backstop, a fail-safe to ensure Medicare remains solvent for years to come. IPAB is comprised of 15 health experts, including doctors, other healthcare professionals, employers, economists, and consumer representatives. The Affordable Care Act provides for consultation between the President and congressional leadership on appointing members of the board, and appointments are subject to the advice and consent of the Senate. Each year, the board recommends improvements to Medicare. The recommendations must improve care and help control costs. For example, the board can recommend additional ways for Medicare to reduce medical errors and crack down on waste and fraud. And contrary to what some have said, IPAB, by law, is not allowed to ration care or shift costs to beneficiaries. In fact, it's specifically forbidden from making any recommendations that would ration care, reduce benefits, raise premiums or cost sharing, or alter eligibility for Medicare. It leaves all final decisions in the hands of Congress. If Medicare spending begins to threaten the program's future, IPAB is charged with making recommendations to Congress to create necessary savings without shifting the cost of care to seniors and those with disabilities. But then it's up to Congress to decide whether to accept those recommendations or come up with recommendations of its own to put Medicare on a stable, sustainable path. In other words, IPAB's recommendations are only implemented when excessive spending growth is not addressed, and no actions are being taken to put spending in line. The Nonpartisan Congressional Budget Office and the Independent Medicare Actuary both predict that IPAB is unnecessary anytime soon, indeed in the next decade, thanks to the work we're already doing to slow rising costs. But we don't know about the future, which is why experts across the country, including independent economists and the CBO, believe that IPAB is needed as a safeguard, and we agree. We believe the best way to strengthen Medicare for today and tomorrow is to fill the gaps in coverage, crack down on waste and fraud, and bring down costs by improving care, changing the underlying delivery system. And that's what we're working to do under the health care law. Over the last 16 months, our department is focused on working with Congress and our partners across the country to implement the law quickly and effectively. And in the coming months, I look forward to working with all of you to continue those efforts. Thank you again, Mr. Chairman, and I'd be pleased to take your questions.
Chair thanks the Secretary for your opening statements. I will now begin the questioning and recognize myself for 5 minutes for that purpose. And I have a couple of questions I'd like to ask you to respond yes or no. Very concerned about IPAB. And assuming the cap is reached, suppose we reach a situation where IPAB then kicks in. I'd like to walk through a couple of potential scenarios. Is it possible for IPAB to cut provider payments for dialysis? Yes or no, if we reach that situation?
Mr. Chairman, the IPAB is directed by law to take into account any cut in provider services before they make recommendations.
But the answer is yes, they may cut provider payments.
They don't make any cuts whatsoever. They make recommendations to Congress.
For cuts in dialysis. So if they make a recommendation for cuts for payments for dialysis, if those occurred, would at least some providers no longer be able to provide dialysis services? Yes or no?
Mr. Chairman, I have no idea what the scenario is, what the recommendations are, and what Congress would do with those recommendations. But I assume that we would have that information if we had a real example.
If their recommendations took place, would some...
What are the recommendations, sir, and what is the payment cut, and what is the rate at which providers would be repaid, and in what scenario, and over what kind of period of time? I have no idea.
Is it possible that some providers could be cut?
By?
If those recommendations took place?
If Congress accepted the recommendations and made a decision that cuts in dialysis were appropriate, I assume that there could be some providers who would decide that that would not be a service they would any longer deliver, the same way they do with insurance coverage each and every day, that providers make determinations
if
whether
that
they be part of the
occurred,
network.
Would fewer providers, as you have suggested could occur, mean that some seniors would have to wait longer for dialysis? Yes or no?
Mr. Chairman, as you know, any cut in services, certainly cost shifting to beneficiaries, could mean huge reductions in care that seniors would have the opportunity to receive. What we have right now is guaranteed benefits. What I think the House Republican plan would do is shift that to a guaranteed contribution, which would dramatically change the ability of seniors to access care.
Yeah. In this case, we're talking about the law, not a proposal in the Republican budget. IPAB is commanded to save money by cutting reimbursements. They will have to make the decisions about which services are more or less critical, what patients can wait longer. Is that not rationing?
Mr. Chairman, IPAB is not directed to make recommendations based on cuts and reimbursements. It's directed to make recommendations based on ways to reduce costs overall if indeed the Medicare spending targets per capita exceed what the actuary hits as a target goal. I think that there are a variety of areas, and one is the work we're currently doing in the Partnership for Patients, where you actually go after costs that are unnecessary and being paid right now in the system, $50 billion worth of costs for care that should have never been realized in the first place. Those are the kinds of recommendations I think that are significant and could have a huge impact.
Let me ask you about, again, the statute. Where in the statute is there a prohibition on IPAB making recommendations that could reduce access to breast cancer treatment, say mammograms?
Well, IPAB is forbidden by law to make recommendations that would ration care, and I would say any kind of prohibition on accessing treatment would be rationing care.
Are there any provisions in the law that explicitly state IPAB cannot reduce access to the treatments like that?
They may not, by law, ration care. And I think anyone would suggest that a reduction or an elimination of a treatment is rationing care. That is forbidden by law.
Suppose someone believes that IPAB has, in fact, rationed care. What redress does that person have to challenge the board's decisions?
A court challenge.
Are the board's recommendations exempt from judicial or administrative review?
The judicial oversight that is limited is really, I think, regarding my or any future Secretary of HHS implementation of recommendations when they have followed the law. I don't think anyone, certainly our General Counsel, feels very strongly that nothing would, and that language is consistent with language that's currently in the Medicaid statutes, Medicare statutes as they move forward. Nothing would certainly give either the IPAB board or a future Secretary of HHS or the current Secretary of HHS any ability to violate the law, and that would always be subject to judicial review.
Chair, thanks, gentlelady. Recognize the ranking member, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. Madam Secretary, while today's hearing is on IPAB and its consequences to seniors, we've yet to hold a hearing in this subcommittee on the Republican plan for Medicare, even though I've asked for that many times. And as you recall, the Republican budget ends the Medicare program. IPAB's effects do not compare to the consequences for seniors of the Republican budget. Over the next 10 years, the Republican budget proposes to cut Medicare by $32 billion. CBO believes that IPAB will save about $2 billion over that same time period. So the Republican budget would cut 13 times as much in the next decade, and that's even before they begin their plan to end Medicare starting in 2022. I hear the Republicans accuse the Affordable Care Act of rationing care. First it was the death panels, then the government takeover, and now it's IPAB. But the Republican plan for Medicare was so destructive it would actually end Medicare's guaranteed hospital benefit. It would actually end Medicare's coverage for surgical care and for chemotherapy. And coverage for all of those services would be entirely dependent on whether you could first convince a plan to cover you, and then on whether the plan includes hospital services or chemotherapy in its benefit package. And as you know, these kinds of problems are endemic in the individual insurance market, and that's why we have so many uninsured today, and that's why we passed the Affordable Care Act to guarantee a good benefit package and eliminate a lot of the discrimination. I just wanted to ask you, what do you think the Republican budget plan would mean for beneficiaries who would no longer have their Medicare benefits?
Well, Congressman, I don't know, and I don't know that anyone knows all the details of what the Republican plan is. What we do know is what is there in terms of numbers, that the current plan of giving a senior or someone with a disability an $8,000 voucher beginning in 2022 and having that voucher purchase whatever coverage is available in the private market would shift costs to beneficiaries. So beneficiaries would be paying for about 61% of their cost of care. Currently, they pay under 30%. Within 8 years, they'd pay closer to 70% of the cost of care. In fact, an average senior who's relying on Social Security would be paying about 60% of that Social Security check in 2022 for health care. Right now, it's about a quarter of the Social Security check. So there'd be a huge cost shift. It's unclear what the benefits actually would be available and who makes that determination. I gather that the Office of Personnel Management would negotiate some kind of package, but what kind of benefit package would be mandated or not mandated is a little unclear at this point. What we know is that without controlling the underlying costs and continuing down this path, what the Republican plan does is shift costs onto seniors. And frankly, insurance companies are pretty adept at making decisions about what care is granted and what care isn't granted, eliminating benefit packages, and that's done on a day in and day out basis, as well as determining what providers get paid for what services over what kind of period of time.
Well, you know, the point I'm trying to make is the Republican cuts to Medicare in the future far outstrip anything proposed in the Affordable Care Act, including IPAB. And we have to remember that Republicans objected to all of the savings in the Affordable Care Act, not just the IPAB. And despite that, their budget, amazingly enough, proposed to incorporate 96% of the Affordable Care Act savings, all of them essentially, except for the IPAB. I just wanted to ask you, as I mentioned before, you know, we're talking in a Republican budget that proposes to cut Medicare by $32 billion. CBO says that IPAB will save about $2 billion over that same time period. So the Republican budget cut is 13 times as much. I just wanted you to comment on that or confirm that, if you will.
Well, again, Mr. Chairman, I think there's no question that the Republican budget does contemplate an end to Medicare as we know it, an end to the commitment that seniors will have benefits guaranteed once they turn 65, be able to choose their own doctor, be able to choose the health system that they find best treats their situation, and reliably understand that they won't go bankrupt because of care delivery. So that period would come to an end, and it would be a voucher system in a private insurance market, which is a very different kind of care delivery and a very different kind of commitment.
Thank you. Thank you, Mr. Chairman.
Chair thanks the gentleman and recognize the Vice Chairman of the subcommittee, Dr. Burgess, for 5 minutes for questions.
Thank you, Mr. Chairman. Let me just continue on that for just a moment. You said that the Ryan plan would define the end of Medicare as we know it. Why does the IPAB not provide a similar definition?
Well, I think, Congressman, the Independent Payment Advisory Board makes recommendations to Congress. It is forbidden by law to do exactly what the Republican budget plan seeks to do.
Let me ask you a question.
They may not shift costs to seniors. They may not change benefits.
As we know from reading the law, it's very, very difficult for people to appeal those decisions. And in fact, we won't even know because no one currently has standing until there's actually implementation of the board, which has not happened yet, and care is denied, and they take it through the courts. But I think we're going to find it's very, very difficult to overturn a decision of this board. Can you tell us the difference between a voucher and premium support?
The difference between a voucher and premium support?
Mr. Ryan's articulated aspirational document in the Republican budget talked about premium support, concept actually introduced during the Clinton administration with the Commission to Save Medicare, the Bro-Frist Commission. On the other side, the talking point is that he's going to give a voucher.
A voucher is basically, in I think, insurance terms, a guaranteed contribution, as opposed to a guaranteed benefit. Those are very different concepts. On one hand, in the current Medicare program, seniors and those with disabilities have guaranteed benefits. That which switch, it's a voucher.
And then what would premium support look like in that world?
Pardon me?
What would premium support look like?
I'm not as familiar with that term. I know what guaranteed contribution is. I know what a voucher is.
So it's incorrect to use the terms interchangeably, as so often happens in this committee. Premium support is a different phenomenon than a voucher. Premium support would be a request for proposals going out to insurance companies to provide the coverage, much as in Medicare Part D, so you should have some familiarity with it.
Well, if you're assuming, Congressman, let me just ask, if you're assuming that $8,000 provides the total benefit.
This is my brief time to be able to ask you questions, so I've got to insist upon that. Now, the budget for the Independent Payment Advisory Board begins October 1st, correct? $15 million?
It is available, yes, sir.
Now, who has been nominated to that board and is awaiting confirmation?
No one.
And why is that?
Well, I think, Congressman, the board is not activated until 2014, and I know that the President is in discussion with a number of potential nominees, and I know he has consulted with various members of Congress, but it will be appointed and up and running at the time.
So can we keep that $15 million that is due October 1st? Because you apparently don't need it to set up the board because...
We have no intention of using money before there is a board up and running.
Well, who does the check go to?
I don't think there is a check. I think there is money available that we would draw down. It is a...
Can we have that money back? We're in a debt crisis. You may have heard.
I understand. I can assure you there will be no drawdown on the Treasury of $15 million until there is a board and a functioning operation.
Now, on this board, are they available to be a recess appointment by the President so that they would not be subject to Senate confirmation like your head of CMS is?
I am not a lawyer. I can't answer that question. I have...
Well, the CRS report that's available on this indicates that there would be the availability of a recess appointment. I count 9 that wouldn't require input from either the Speaker of the House or the Minority Leader on the Senate side. So 9 would be a majority, but in fact you don't even need a numbers majority. You just need a majority of those who've been appointed. Is that correct?
That's correct.
Let me ask you this. It looks like in statute that you could not have a majority of the board made up as physicians. Is that correct?
My understanding is that the prohibition is, yes, that a majority could not be practicing physicians.
Well, who can make up the majority? I mean, the definition of who can be the members is actually a little bit vague. It's peoples with a national recognition for their expertise in health finance. That's an odd pool, but they can actually make up the majority?
Well, I think, Congressman, the
So think tanks can be the majority of this board?
The characteristics of the board members are modeled after the characteristics that were defined for the MedPAC board members, which have very similar kinds of backgrounds and abilities. The very significant difference is that there is a very strong conflict of interest barrier for the IPAB where they could not be receiving payment from the system and making recommendations at the same time.
The man who would have been your predecessor, but he actually didn't get confirmed, Tom Daschle, wrote a book called Critical. I don't recommend anyone buy it. But he talks about this board. This board was something that he extolled in this book to a great degree, but it was actually patterned more after the Federal Employee Health Benefits Program, which is in fact employer-sponsored insurance. Is it your vision that one day this board can be spread to further than just the Medicare world, but could actually control the private health insurance world, much as the Center for Consumer Information and Insurance Oversight now envisions controlling the private insurance market as well?
Again, Congressman, the board doesn't control anything. They make recommendations to Congress in the event that Congress has not acted to keep Medicare solvent. That's a recommendation board. They don't control the Medicare program. Congress is in the driver's seat. They make recommendations, and I think that could be very helpful as we look for ways to preserve beneficiaries' right to health insurance and look for a program to be solvent on into the future.
Regular order, Mr. Chairman.
Chair thanks the gentleman and recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Thank you, Mr. Chairman. Madam Secretary, I'm pleased to see you, even if you don't see me. Now you do. You've been pressed on whether this is a premium support or a voucher. It's hard to distinguish it, but as I understand it, premium support would keep increasing the amount of money that would be available for people to buy insurance, like Part D Medicare, so that the amount of money would keep up with the costs. A voucher, as I understand being proposed by the Republicans, although we haven't seen detail, is a defined contribution with no increase, no matter what the cost increases may be in medical care. But I want to explore with you a different issue. We're hearing a lot today about all the things that IPAB is allegedly going to do to the Medicare program. We've also heard you describe all the things that IPAB can't do, like denying benefits and increasing costs for beneficiaries. I'd like to know how the Republican plan for Medicare stacks up against all of the things that IPAB can and cannot do. For example, the Republican plan would end Medicare's guaranteed benefits for things like hospital stays and doctor visits. They would replace it with a cash voucher. Can IPAB do that?
No, they cannot.
The Republican plan would increase cost sharing for Medicare beneficiaries, more than doubling their out-of-pocket costs for new enrollees. Can IPAB do that?
Well, there's no, the IPAB board cannot make recommendations that would do that kind of cost shifting.
The Republican plan proposes to increase premiums and force people to negotiate their care with private plans on their own. Can IPAB do that?
There is no ability in the law, I think, to make those kinds of recommendations that would change the beneficiaries' benefits. No.
In fact, IPAB is prohibited from making all of these changes that would be harmful to beneficiaries, but the Republican plan enacts them all. Are you aware of any proposals in the Republican plan that would save money by reducing costs and not by shifting them to the beneficiaries?
I have not seen any details of delivery system changes or cost reductions. No, sir.
Well, I think the right way to reform Medicare is to make care more efficient, the way we started to do under the Affordable Care Act. The wrong way is to wash our hands of the problem, putting all of the costs onto the Medicare beneficiaries. Secretary Sebelius, at yesterday's hearing before the House Budget Committee, there was a major topic of conversation about the ability of Medicare patients to see their doctors when they need to. And that's an important issue for all of us to monitor. But the premise of many Republican questions seems to be that Medicare patients are unable to see their doctors today. This is similar to their bizarre claim that it's better to be uninsured than to have Medicaid. Are you aware of any information on whether Medicare patients are more or less able than private patients to see doctors of their choice?
No, sir. In fact, about 98% of the physicians in this country are enrolled in Medicare. I know that there are pockets in communities where doctors are just overbooked, but that would apply to private pay and Medicare patients.
Surveys from the Medicare Payment Advisory Commission and numerous other independent surveys all confirm Medicare patients have access to care, at least as good as the access private insurance patients enjoy, if not better. That's for primary care and for specialists. Now, certainly, we need to address the SGR if we're really going to guarantee access in Medicare for the future. But that problem exists whether we repeal IPAB or not. There's another problem with the Republican claims about access problems under the Affordable Care Act, Medicare savings. Republicans adopted all of those savings provisions in their own plan until they end the program in 2022. The Affordable Care Act is the Republican plan for Medicare, excluding IPAB. Do you know, Madam Secretary, how much of the Act's Medicare savings was from the IPAB? I'll tell you, because you may not know. It was 4%.
Yeah.
4%. So Republicans embrace 96% of the Act's cost savings in Medicare. They pile on trillions in cuts over the next several decades when they end the Medicare program, and they suggest that Affordable Care Act will cause access problems, but that their voucher plan won't. It doesn't add up, and it doesn't make sense. I want to ask you one last thing about, well, I'll tell you what, I'd go over my time, and I would like to give other members their opportunity to ask questions. Thank you for being here. Thanks for responding to the questions.
Chair thanks the gentleman and recognize the gentleman from Georgia, Dr. Gingrey, for 5 minutes for questions.
Mr. Chairman, thank you. Madam Secretary, thank you for appearing. You know, we're here to talk about IPAB, Independent Payment Advisory Board, not today at least, to express our outrage over Obamacare in general, but it seems like the discussion has expanded a bit, maybe on both sides of the aisle. I must say I'm a little bit surprised on the question in regard to the difference in a voucher and premium support You seem to struggle just a tad over that. A voucher, as I understand it, is sending someone a check on a monthly basis to spend on health care at their own volition. They could basically, I guess, sign up for holistic medicine. They could have an acidity bag around their neck. They could essentially do anything they wanted to with that voucher, whereas premium support in the plan for prosperity, the Republican plan to reform and save Medicare for our current seniors and our future generations, is talking about premium support where the Center for Medicare and Medicaid Services, basically where the senior designates they want to purchase their health insurance, a plan that best fits their needs, that premium is advanced to the insurance company as payment for those services. It doesn't go directly to the patient. So that's the big difference in a voucher versus premium support, and I think we should describe it accurately. IPAB, in its report to Congress, is charged under Obamacare with including, and I quote, recommendations that target reductions in Medicare program spending to sources of excess cost growth. Madam Secretary, can you tell us where in Obamacare the term excess cost growth is defined?
Sir,
well,
I don't know if there's a statutory definition. I do want to respond briefly to your premium support issue.
Well, no, look, we're beyond that. Now, my time's limited, and I'm just going to help you on this second question. It is not defined. Excessive cost growth in Obamacare is not defined. Peter Orszag, in fact, President Obama's former OMB director, has defined the excessive cost growth in Medicare as principally the result of new medical technologies and services and their widespread use by the U.S. health system. That's what Peter Orszag thinks is in regard to excessive cost. Let me ask you this question. The head of CMS, Dr. Donald Berwick, interim head of CMS, and it's likely that he will remain interim, has been quoted as saying, most people who have serious pain do not need advanced methods. They just need the morphine and counseling that have been available for centuries, end quote. Do you believe, Madam Secretary, do you believe that limiting advanced methods to sick seniors in favor of morphine and counseling is an appropriate way to reduce Medicare costs? Yes or no?
Congressman, I believe that seniors have a right to make choices with their doctors, which is what they do now under the guaranteed benefit program, under the Medicare system. Under an insurance plan, that would no longer exist. And I would also suggest that premium support typically means that there is an enhanced benefit. And as
well,
you know,
Madam Secretary, I agree with the first part of your
30%.
response. It should be between the doctor and the patient, and you don't get that with IPAB. Madam Secretary, I'm aware that the statute states that IPAB cannot propose plans that ration care. Can you tell me where the word rationing is defined in the Obamacare statute?
It is not defined, sir.
Well, you're absolutely correct on that. It is not defined. During questioning before the House Budget Committee yesterday, you referred to IPAB as merely a safeguard and a stopgap, noting it will only come into play if Congress failed to reduce Medicare spending. In fact, wouldn't be recommending any cuts for the next 10 years. Yet on Wednesday, April 13th, President Obama, in laying out his plan to reduce health care spending to the American people, stated that IPAB was a major plank in his plan to make additional savings in Medicare. Madam Secretary, if President Obama had stated publicly that IPAB is a major plank of his plan to save Medicare, and you are saying that IPAB, it's just a backstop to Congress coming up with a plan, should the American people infer from that that Obamacare is the president's grand plan to save Medicare? Give me a yes or no, or if you want to expand a little bit and the chairman will allow, I would like to hear your opinion on that.
I don't think there's any disagreement between the President and my statement. The way that the Independent Payment Advisory Board is structured is that recommendations are made on a yearly basis, and recommendations are only impactful if indeed Congress has not taken the advice of the independent actuary that per capita spending has exceeded a targeted goal. If indeed the IPAB recommendations are not ones that Congress chooses to accept, they change the recommendations or move in a different direction, and the recommendations never have any impact if indeed cost trends are below IPAB. Below the independent actuary's targeted goals. So it is a backstop. It is a backstop for Congress taking the responsibility to keep Medicare solvent into the future. If indeed they don't act, there is a mechanism where these recommendations become law, absent Congress rejecting the recommendation.
Well, I've gone way over my time, and I'll just close out by saying I agree with Mr. Pallone and Ms. Schwartz that we ought to repeal IPAB. It is wrong-headed, it is boneheaded, and I yield back.
Chair, thanks, the gentleman. Recognize the gentlelady from California, Ms. Capps, for 5 minutes.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for being here today. You know, I've been listening to this discussion. I've met with advocates in the past few months on both sides of the IPAB issue. The one thing they share is a concern for the unknown. One common concern is that due to protections for hospitals and other groups from IPAB changes before 2020, the only thing left to cut would be to cut provider rates. Others note that this is not true. We've heard the same kind of discussion today. Can you please address this issue? What could IPAB recommend other than provider payment cuts?
Well, I can give you a few quick examples of things that are on the table as we speak. For years, there was a recommendation out of MedPAC, who can only, make recommendations that we look at the overpayment to Medicare Advantage plans. That was never accepted by the United States Congress, and yet when the Affordable Care Act was put together, Congress decided that that was an appropriate area to look at. Medicare Advantage, the private market strategy for Medicare, which was supposed to introduce competition and choice and drive down costs, now runs at about 113% of the fee-for-service plan with no health benefits. So Congress implemented the changes recommended by MedPAC for years, and over the course of the next 10 years, the Congressional Budget Office says about $140 billion will be saved. That is an example of the kind of strategy that has been on the table. If it had been implemented years ago, $140 billion less would have been paid out over the last decade. But an overpayment, no health benefits, seniors will still have choices. We have a very robust program. We've begun to decrease the overpayment to Medicare Advantage plans. But I think that's a strategy that is in the Affordable Care Act. It is exactly the kind of strategy that I think is anticipated by this independent board.
Thank you. Conversely, the Republican majority has voted unanimously to essentially end the current Medicare program. The known, now not hypothetical, but known result would be a doubling in out-of-pocket costs for beneficiaries who would get a limited amount voucher to cover a fraction of the cost of private insurance. It would leave our seniors and persons with disabilities on their own to haggle with insurance companies without any guarantee that there would be any policies available to them, let alone that they would be affordable. Madam Secretary, some talk about the Republican plan as a way to cut costs, but all I see is a huge cost shift, placing the financial burden on seniors with limited incomes without any meaningful reforms in the plan to actually address the overall cost of health care. Are there, as you have analyzed the Ryan budget plan, are there any cost containment strategies in it that to privatize Medicare? Does that privatizing include any cost containment that you notice?
Congresswoman, we have not been able to identify cost containment strategies, and as I say, the case in point of Medicare Advantage which has been in existence for years, which was specifically put on the table to introduce cost and competition, was anticipated to drive down costs, has done just the opposite. It is running at about 113%, and every Medicare beneficiary, all 49 million beneficiaries, pay an extra $3.60 per member per month to pay for the additional supports for Medicare Advantage program. That will, again, be gradually over time decreased, and I think thanks to the Affordable Care Act, that excess payment will cease to exist.
I think all of us in Congress understand the need to rein in health care spending. In fact, that's why so many innovations in the Affordable Care Act are set up to do just that. Can you now, I just have a few seconds, you have a few seconds, if you could talk about some of those aspects of the law. You mentioned Medicare Advantage. What are some of the other parts of the Affordable Care Act, particularly as it relates to Medicare, opportunities for cost containment?
Well, I think, Congresswoman, certainly through the Innovation Center, we're already seeing some very exciting delivery system reform, which is really the underlying healthcare delivery system. So the Partnership for Patients goals, which I think are very on point, and not only impact Medicare, but impact everyone who goes in and out of the hospital. Reducing hospital-acquired infections, which kill 100,000 people in America every year, cause hundreds of thousands of people to stay in the hospital longer and put them in worse physical condition, but cost billions of dollars, and reduce unnecessary readmissions, where 1 out of 5 Medicare patients cycles back to the hospital within 30 days. Many of them have never seen a health care provider. Those two initiatives, which already 2,000 hospitals and countless other partners have signed up to participate in, will reduce Medicare spending by $50 billion. Better health care at lower cost.
Thank you very much. You're back.
Chair, thanks, gentlelady. Recognize the gentleman from Ohio, Mr. Latta, for 5 minutes for questions.
Well, thank you very much, Mr. Chairman, and Secretary, thank you very much for being with us today. If I could just go back on the line of questioning that Dr. Burgess had, is there anything in the law that says how many members have to be appointed before the board starts functioning?
Not to my knowledge, sir, but I can.
Okay. Well, the reason I asked that, with 15 members, could 3 members actually be appointed and start functioning as a board? Because, and just looking at what the law says here.
I'm sorry, I'm really having a very hard time hearing you.
I'm not
so
sure.
Sorry.
I probably talk louder than this microphone's picking this up.
I'm putting my ear up to the microphone, but that really doesn't help.
That might help. I tell you, this is the energy, and we have technology here too.
Sorry.
But it says under the act, it says quorum. A majority of the appointed members of the board shall constitute a quorum for the transaction of business, but a lesser number of members may hold hearings. But again, I guess the question is, if you've got only 3 members appointed, can they start functioning as the board? And then actually you could have fewer members of that 3 actually start holding hearings. Is that possible?
Well, I certainly think fewer than a quorum could start holding hearings, and I would think that outreach function is critically important for any board who's going to make recommendations. I do not, I'd be happy to get you the answer in writing. I don't want to speak outside of the.
Yeah, I'd appreciate that if you could. And if I could just go to your testimony on page 12. You said that the IPAB cannot make recommendations that ration care, raise beneficiary premiums or cost sharings, reduce benefits, or change eligibility for Medicare. The IPAB cannot eliminate benefits or decide what care Medicare beneficiaries can receive. Given a long list of additional considerations the statute imposes on the board, we expect the board will focus on ways to find efficiencies in the payment systems and align provider incentives to drive down those costs without affecting our seniors' access to care and treatment. Okay, if they're not going, so what we're saying is then they're going to have pretty much the power of the purse. Would you say that would be the recommendations that they would have in this case, then, that they'd have that power of the purse that say what if they're not making the recommendations as to what care or that a person would be receiving, but they're going to be able to say how much money is going to be expended? Would that be a correct statement?
I think, Congressman, again, they are recommendations that come to Congress. They are triggered at a point where the independent actuary sets a per capita spending target. Actions have not reached that spending target, so they will make recommendations about appropriate ways to reach that within the bounds of the law.
Okay. So going along those same lines, though, again, if someone has the recommendations of the power of the purse, and they're saying, well, we're going to have to reduce, and I've already mentioned a little bit a little earlier in some other questions, how are we going to make up for those doctors and hospitals if their payments are going down? Wouldn't they then have to cut back on the patients they see and the care that they provide?
Well, again, I think, Congressman, I tried to give with Congresswoman Capps an example of the kind of strategy that can yield enormous cost savings without jeopardizing care or jeopardizing the kind of relationship between doctors and their patients. And that's really what's envisioned. I think a fundamental tenet of the current Medicare commitment to seniors and those with disabilities is the ability to choose one's own doctor, the ability to choose one's own care system, and the knowledge that you have benefits that are available to you. That ceases to exist under the plan supported by the House Republicans, and I think that IPAB serves as an ongoing yearly group of experts who are not being paid by the system to make recommendations to Congress, who can act on those recommendations or not.
Well, because again, I represent a rather large area in the state of Ohio, a lot of rural areas that have a lot of community hospitals. You know, they're all very, very concerned about reimbursement. I've got a lot of my doctors that are very concerned about reimbursement, and so, you know, as we were looking at this, you know, they're reading this too, and you know, they read this, the testimony about you know, driving down costs and trying to, you know, for payment systems and line provider incentives. They're nervous about on their payment. And Mr. Chairman, I see that my time has expired, and I yield back. Thank you.
Chair, thanks the gentleman, and yields 5 minutes to the ranking member emeritus, gentleman from Michigan, Mr. Dingell.
Mr. Chairman, I thank you for your courtesy. Welcome back to the committee, Madam Secretary.
Thank you, sir.
Your father served here with distinction. It's a particular pleasure to see you here this morning. Madam Secretary, do you believe that the emphasis on annual recommendations will limit the board's focuses to short-term fixes rather than lowering our nation's health care spending in the long term? Yes or no?
No.
Madam Secretary, under the Republican plan, nothing will prevent private insurance companies from raising care. Is that right?
I'm sorry, nothing?
Under the Republican plan, nothing would prevent private insurance companies from rationing care. Yes or no?
That is correct. There's no prohibition.
All right. Now, IPAB is legally prohibited in the legislation from making recommendations that would ration health care. Is that right?
Yes, sir. There is a prohibition for rationing care, shifting costs to beneficiaries, eliminating benefits.
Now, Madam Secretary, who's in charge? Under the Republican plan, the insurance companies. The Republican plan would, is that right?
If I understand it correctly, yes, the voucher would be paid to an insurance company.
It also, the Republican plan ends Medicare as we know it and repeals the Affordable Care Act, giving free rein to the insurance companies to decide what care you can get and when, with no clear limits to protect consumers or prevent insurance companies from taking in exorbitant profits. Is that right?
Well, the various features, including the medical loss ratio and consumer protections and rate review, would all be eliminated with the Affordable Care Act, and companies would then be in charge of seniors'
Now, under the Affordable Care Act, the individual and that individual's doctor would be in control of matters, and the President's plan maintains Medicare as we know it. Is that right?
Well, it is a plan that maintains the Medicare benefit package, understanding we need to look seriously at outgoing costs.
And the plan remains a defined benefit plan. Is that right?
That's correct.
Which under the Republican plan it is not. It's a defined payment plan. Is that right?
Yes, sir.
All right. Now, the Republican plan would eliminate Medicare's guaranteed benefits and limits on cost sharings and premiums. Is that right? Yes or no?
Yes.
Instead, insurance companies could determine which benefits seniors on Medicare would receive and how much they would pay. Is that right?
I assume so, sir. I don't think there's any written language about what the benefits would look like.
IPAB is under the President's plan. The President is, rather, IPAB is legally prohibited from cutting premiums or increasing premiums and co-payments. Is that right?
Yes, there cannot be cost shifting onto beneficiaries.
Now, under the Republican plan, health care costs would rise, which turns Medicare over to private insurers that have higher administrative costs and profits. Is that right?
Yes, sir. Currently, the Medicare program runs at under 2% administrative costs, and I think the most efficient private insurers are at about 12 to 15%.
Now, IPABs will make decisions based on what's best for seniors and Medicare, and not who spends the most money in Washington. Is that right?
By law, they are directed to protect the beneficiaries as they make recommendations.
All right. Now, Madam Secretary, how will you and the board ensure that consumers' and patients' views will be taken into consideration as the board drafts its recommendations?
Well, Congressman, I think that there's no question that the President will look for members of this board who are eager to not only participate in the long-term solvency of Medicare, but also pay close attention to the protection of the beneficiary, which is part of the fundamental
We also will
direction.
have public hearings on these matters.
Public hearings,
right.
I think the appointment of people who don't have a conflict.
Is it your belief that the board would benefit from soliciting public comment prior to issuing its recommendations in
Absolutely.
a manner similar to that specified in the Administrative Procedures Act?
Yes, sir.
I guess we can say that's a commitment on the part of the department. Is that right?
Yes, very much so.
Madam Secretary, it's always a privilege to see you. Thank you, Mr. Chairman, for your courtesy.
Chair thanks the gentleman and recognizes the gentleman from Louisiana, Dr. Cassidy, for 5 minutes.
Hey, thank you for being here, Secretary Sebelius. And if every now and then I cut you off, I'm not being rude, but it's so valuable to have you here. I'm just trying to stay focused, and I apologize at the outset. I'll also say to my Democratic colleagues, Republicans do retain the savings, yes, 96% of them, but we put them back into Medicare as opposed to spending them on another entitlement. And I think that is the difference between the two of us. Secretary, I am a doctor who works in a hospital for the uninsured, but 20 to 50% of my patients have Medicaid. So I think it's fair to stipulate that when public insurance programs pay physicians below cost, then they really don't have access. It may be access in paper, but it's not access in power. Now, that said, Richard Foster currently estimates that under current law, in 9 years, Medicare will pay physicians below what they receive on average from Medicaid. Now, is it fair to accept is it fair to accept with the given stipulation that that will hurt access of Medicare patients to their physician?
Well, I don't think there's any question, Congressman, that underpayment of any kind of provider certainly jeopardizes an adequate network, whether it's a private insurer or a public payer.
Now, if MedPAC, already knowing that under current law, physician reimbursement is cut by 21% in the near future, I'm sure you'll agree that that would have a disastrous effects upon a patient's access.
I mean, failing to fix the SGR.
And, of course,
yeah.
Part of the savings of SGR is into the $1 trillion of savings that the other side of the aisle claims for Obamacare. So I will tell you, as a patient that sees Medicaid patients at a hospital for the uninsured, when I read that this board has the limited ability to cut, but where they can cut is reimbursement to providers, I actually see that what we're really doing is effectively denying access. Now, I will also say that I've learned that rarely do government institutions admit that they are rationing. Rather, the queue gets longer. Would you disagree with that, or do you think I'm wrong?
Well, Congressman, I think that there's no question that, again, I think the Republican budget plan on Medicaid.
No, I'm really speaking about current law.
I'm really speaking. Medicaid
I see that you're pivoting here, but if we can stay on the current law as opposed to the pivot. Again, when we speak of a board which has limited ability to save money except by cutting payments to providers.
Well, that's not accurate, sir.
Okay, so it can also do Medicare Part A, and it can also do pharmacy coverage for dual eligibles. But clearly, a significant portion of it is cutting payments to providers. Now, again, under current law, Medicare will be paying providers less than Medicaid per Richard Foster. It's well documented Medicaid patients have trouble gaining access. So where do we part in our analysis?
Well, again, I think that there are lots of opportunities in the delivery system where we are paying or overpaying for care that probably should never
so
have been
if I may
delivered in the
summarize,
first
you're
place.
saying that there will be savings that will keep this mechanism from being I gather, that keep this mechanism, this IPAB, this denial of care board from having to act. I will say parenthetically that the New England Journal of Medicine article, which I'm sure you're familiar with, shows that accountable care organizations have not saved money in the under the more favorable rules in which the pilot studies have been done. But going back to my point.
Some of them did, some didn't.
3 out of 10 did. 7 didn't. So coming back
So
to
we
the
learn
current
from
law.
that and go on.
Coming back to current law, because we really can't say, oh, don't worry, if this works out, this will never happen. Let's just assume that it does happen. Again, if we decrease payment to providers, and we know from experience that that will decrease access, does that not trouble you?
It does, which is why I think Congress carefully wrote into also the parameters for the Independent Payment Advisory Board that at every step along the way, provider access had to be part of their overall recommendations.
It has to be part of the
overall. They make recommendations
coming back to
this, Congress.
Clearly, Medicaid, by law, has to provide access to for pregnant women and pediatrics. By law, they're supposed to pay adequately to give that access. And yet there's a recent New England Journal of Medicine study that shows that those with Medicaid or CHIP actually are more likely to be denied access to an appointment. In fact, 2/3 of the time they're denied such access. Doesn't that give us pause that despite that law, that they're guaranteed access? For the privately insured, it's only 11% that you can't get an appointment. For the publicly insured, it's 2/3. I mean, do you not see a danger that this will be the case with this IPAB board?
Well, again, IPAB has no authority to cut anything. They make recommendations. And secondly, as you know, sir, the governors of various states set provider rates in their Medicaid programs. They are vastly different in Louisiana than they are in
This is on average, and I think the New York Times is well documented in the states as desperate as Louisiana and Michigan that is the case. It's disingenuous to think otherwise, but that's okay. I'm out of time, and I yield back.
Chair thanks the gentleman and recognizes the gentlelady from Illinois, Ms. Schakowsky, for 5 minutes for questions.
Yeah, I think this discussion is just really ironic, this attack on IPAB, given the fact that the Republican plan would instead turn over the Medicare program to private insurance who would have no constraints whatsoever in raising their rates and causing huge doubling of out-of-pocket costs for beneficiaries, and this semantic debate whether it's vouchers or premium supports. The only difference is where the check is sent to, where the inadequate check is sent to, and if we want to have a semantic debate, we ought to change the name, because what they're proposing is not Medicare. We could call it sort of care or maybe care or I don't care, but it's not Medicare anymore, according to what my understanding of Medicare, which, as you pointed out, Madam Secretary, is a guaranteed benefit plan. That is the essence of Medicare. The other thing is, I don't know for sure if you know the answer to this, but My understanding is that the Republican budget includes all of the Medicare savings provisions that you so wisely helped to navigate and talked about from the Affordable Care Act, with the exception of IPAB. Isn't that true?
That's my understanding.
And those include those kinds of changes that have been made that they accuse the Democrats of, cutting Medicare and that these are reasonable savings. Is it also true that there was a May 26, 2011 letter to Representative Waxman from the CBO projecting that Medicare will not exceed the specified targets during the 2012 to 2021 period, and therefore that IPAB will not be triggered during that period? I know you said that. I'd like for you to restate that expectation.
Well, I think thanks to the impact already of some of the strategies in the Affordable Care Act and some really unprecedented new tools, not only in fraud and abuse, but in delivery system ability to align payments with high-quality, lower-cost care, we are already seeing a cost trend that is diminishing. And the actuary has projected that at no time there is a slight possibility that in 2018 there would be a brief recommendation period, but he basically says that for that 10-year period, it's very unlikely that IPAB ever have. They will be meeting and making recommendations, but in terms of having to meet a spending target, will not occur.
Once again, I frankly was really a bit surprised and happy to see that there's this new study that says that 93% of physicians are taking new Medicare patients, but only 88% of physicians are taking new private patient plans, or new private plans. The issue of access, I think, is on everyone's mind, and clearly we do not want to see doctors refusing to take Medicare patients. So let me ask you to, again, I think it is once again, but again, address this issue of access to care because with IPAB.
Well, again, I think that the goal is to make sure that Medicare is solvent not only for the next number of years, and as you know, the Affordable Care Act has already extended the solvency projections, but on into the future. And so the strategies really are aimed at trying to make sure that we not only have patients' ability to choose his or her own doctor, a fundamental tenet of the current Medicare plan, very different than if you are in a private insurance plan where that physician, that hospital system, that pharmacy, that set of benefits is pre-chosen for you. So access to your own doctor, having patient-driven strategies, and making sure that as recommendations are made about any kind of cost reduction on into the future, that we pay close attention to patient access to providers. That is part of the framework of the Independent Payment Advisory Board, and it's one that I think the board would follow very seriously. Certainly we would at the Department of Health and Human Services pay very careful attention to anything that jeopardizes care delivery, and certainly having access to a physician jeopardizes care delivery.
Thank you. And let me just say that I want to thank you so much for your leadership in making sure that we can finally reach a time when all Americans have access to quality health care. Thank you.
Chair, thanks, gentlelady, and recognize the gentleman from New Jersey, Mr. Lance, for 5 minutes.
Thank you very much, Mr. Chairman. Good morning to you, Madam Secretary.
Good morning.
I'm interested in the process regarding the IPAB because, in my judgment, oftentimes process relates fundamentally to policy. And you have indicated, Madam Secretary, that the President has not yet chosen to appoint any members of IPAB. might you give the committee a time frame when, in your opinion, the President might begin to appoint members to the board?
Sir, I don't know about a specific timetable. I know it's absolutely the President's intention that by the time the IPAB provision would begin to operate, there will be members of the board. As you know, the independent actuary doesn't make a target recommendation until 2013.
2013.
It comes to Congress in 2014.
But it's your best judgment that President Obama intends to make appointments in his term of office, the term of office ending at the end of 2012.
I think President Obama intends to make appointments so that the IPAB can be operational at the time that it's operational.
Thank you. The law suggests that he makes several of the appointments in consultation with the leaders, Speaker Boehner, Leader Pelosi, Leader Reid, and Leader McConnell. Is that accurate?
Yes, sir.
And is he required to appoint those whom the leaders have suggested, or is it merely consultative?
It is consultative.
So, for example, he would not be required to follow through on the suggestions of any of the four leaders.
That's correct, although the Senate has a confirmation ability, and I would feel that their consultation might be fundamental in getting folks confirmed.
Perhaps that's so. That's obviously for the other House of Congress. Now, regarding how we in the legislative branch can discontinue the automatic implementation process for recommendations of IPAB, and this is down the road, and for example in 2017. As I understand it, a joint resolution discontinuing the process must meet several conditions, including the fact that it would require approval by a supermajority of 3/5 of the members of the Senate. Is that accurate?
No, sir. The recommendations to be changed by Congress operate in the normal rules of the congressional structure. Now, the Senate seems to do everything by a vote of 60, but there is certainly no requirement that IPAB be rejected and substitute recommendations be made by a supermajority. I think it's only to repeal IPAB itself, to get rid of the board. It's my understanding that that is a supermajority written into the law, but not to accept or reject the recommendation.
So, to follow through on your expertise, and you're obviously expert on this, to get rid of IPAB, the underlying PPACA law requires a supermajority in the Senate?
Right. Well, in the repeal of the Affordable Care Act,
yes,
the House has taken action to repeal the Independent Payment Advisory
yes.
Board. It's my, and again, I apologize. I don't want to misspeak. It's my understanding that if that were done independently, that would require some kind of supermajority. Oh, just in 2017.
Yes, in 2017.
Just that 1 year,
yeah.
It would require supermajority.
Well, in my judgment, that is unconstitutional, and I'm wondering whether the lawyers at your department opined on whether that provision is constitutional or unconstitutional, recognizing that we all rely on the advice of those who serve us in legal capacities.
I have been advised, Congressman, that our lawyers feel that the structure and the operation as described by law of IPAB is constitutional. I'd be happy to go back and get a very specific answer to that question.
My time is up. It is my judgment that that provision, at the very least, is unconstitutional and not in accordance with the current provisions of the American Constitution. Thank you, Mr. Chairman.
Chair thanks the gentleman and recognize the gentleman from Texas, Mr. Gonzalez, for 5 minutes for questions.
Thank you very much, Mr. Chairman. Welcome, Madam Secretary. This is a quote, and I'm just, since this is a discussion now about the benefits and such of competing plans, The Affordable Care Act has already been repealed in the House of Representatives. This is the quote. First, I fear that as health inflation rises, the cost of private plans will outgrow the government premium support. The elderly will be forced to pay even higher deductibles and copays. Protecting those who have been counting on the current system their entire lives should be the key principle of reform. Would you agree with that statement?
From what I could hear of it, I do agree.
Well, you just agreed with a Republican Senator, Scott Brown. I just thought I'd throw out a Republican out there that agrees with the position that we've been taking as to the competing plans. And so to give things some context as I lead to my second question would be that 1/2 of Medicare beneficiaries have incomes of less than $21,000. 1/2 have less than $2,095 in retirement assets. 1/2 have less than $30,000 in financial assets. 1 in every 4 Medicare Part D beneficiaries reaches the donut hole. So we've had the Affordable Care Act, and something that I believe has gone unnoticed, and you may have covered it in your statement, and I apologize I got here late. What went into effect this year that will result, and has already resulted, I believe, in about $260 million in savings to Part D beneficiaries when it comes to name brand pharmaceuticals and generics?
A 50% discount did begin in 2010 for those 4 million approximately beneficiaries who will see a 50% decrease in the brand name drugs that they purchase once they hit the donut hole gap.
That's already in place.
It is.
Can you contrast what we presently have in the way of Medicare Part D and within the Affordable Care Act, but what we've had in place, as opposed to what is being proposed by the Republicans and, of course, what we refer to as the Ryan budget, the Ryan plan, Ryan care, whatever you want to call it? Is there a significant difference in the very nature of the benefit that is being provided?
Well, I certainly think that the repeal of the Affordable Care Act would eliminate the donut hole closing, the gap coverage that now anticipates being closed. But beyond that, it's my understanding, Congressman, that there would be a significant change in the poorest seniors who now qualify for both Medicare and Medicaid benefits with the Republican budget as it deals with Medicaid. As you know, right now there is help and support for another approximately 4 million seniors who actually are income eligible they don't ever hit the so-called donut hole and pay out-of-pocket costs because their costs are supported by the federal government. And there'd be a major shift in the kinds of support for the poorest seniors. It would shift from, again, price supports for everything from nursing home care to prescription drug care, and shift to a fixed income, a fixed amount of money in a medical savings account that those seniors could try to use to navigate what are often very substantial health care costs. So I think in terms of the drug plan, there are about 4 million seniors right now who are actually supported with wraparound care, and that would cease to exist also.
The way it's been explained to me, and I'm surely not the expert in the area, and I'm just going to go ahead and read basically. Part D is a defined benefit, so services are specified in law and covered by plans. The Republican plan would leave benefits up to the beneficiary's negotiation with the insurers. Part D's federal contribution keeps pace with drug costs, so beneficiaries and the government split the growth in health costs, and the Republican budget, beneficiaries would bear all of the burden. Is that an accurate description of the situation and the contrast between what we have, what the Democrats have been proposing and supporting, and the latest proposal from the Republicans?
I think so, sir.
Thank you very much. I yield back.
Chair, thanks. The The gentleman, before I yield to Mr. Guthrie, you mentioned there would be a judicial review for the implementation of IPAB recommendations. Before I yield to Mr. Guthrie, I'd like to the record to show on page 420 of the Act, section 3403E5 states there should be, quote, no administrative or judicial review under sections 1869, section 1878, or otherwise of the implementation by the Secretary, end quote. That means there's no judicial review of IPAB's recommendations.
Mr. Chairman, the question that was posited to me was a question that assumed that IPAB operated outside the scope of their authority, outside the scope of the law. In that case, our General Counsel feels very strongly that there absolutely is a judicial review right. So in the implementation that falls within the scope of the law, that is the case that you
Chair, thanks, gentlelady, and recognizes Mr. Guthrie for 5 minutes.
Thanks, Madam Secretary, for coming. I appreciate you being here. The question first, you seem well-versed in the Republican budget. How many people that are 65 years old today and older are affected by that budget? How many people will be affected in Medicare that are on elderly on Medicare today?
Well, I think the Republican budget would dramatically affect the poorest seniors in its impact on yes, the dual-eligible seniors who are over 65 today would immediately see a cut in their benefits and in their payments going forward.
People receiving Medicare today wouldn't be affected.
Well, those seniors are on Medicare today.
Well, I know,
the poorest seniors in this country would be immediately affected by the Republican budget.
But on that, you know, the president today is talking about raising taxes on people making $200,000, $250,000 or more, and supports that. The administration supports that. If somebody's 54 years old today, when they're 65, if their income is $250,000 or more, why should they not pay more for their health care? We want them to pay more taxes, or the administration does. Why shouldn't they be more responsible for their health care? Why should they be treated the same as somebody who lives the dual eligibles? Why should they have the same payment as that?
Well, I think the president's concept of shared sacrifice is that people contribute a fair share.
But not in health care, not in terms of their Medicare.
In terms of Medicaid, no one qualifies for Medicaid who is making $250,000 a year.
But if somebody is 65 years old, they qualify for Medicare regardless of income.
If
somebody is 65 years
everyone
old,
who reaches the age of 65 in America qualifies for Medicare.
So my question is, why shouldn't somebody that's 54 today, 11 years from now, when our budget would go into effect, not be required to pay more for their health care if you talk about shared sacrifice?
Well, the current Medicare structure has income-related premiums in a variety of the programs. That's part of the program right now.
But right now, currently, there's a study, the Urban Institute, I think you've seen it. It's about 1 to 3, what people pay into Medicare, what they take out. The average of the Urban Institute said, I think it's $109,000. The average couple pays into Medicare and takes out, or will expend $343,000 in health care costs over the course of their lifetime. And I don't think it should be one for one. What dollar you get and dollar you get out. I'm not. But given that the baby boomers are retiring, 1946, they turned 65 this year. I'm 1964, the end of it. Just demographically, these kinds of costs just can't be withstood in the system. And I know, and the system as it is, if you're saying we're going to leave the system as it is and try to make it up in efficiencies is what seems to be, or provider reimbursements, I don't see when we get to 2024, which is the point where it's how it becomes sustainable without reforming and changing the program, not just trying to make it on just pure efficiencies. I don't see where you can make that kind of income difference or that kind of difference.
Well, I would agree that I think we certainly understand that Medicare, as it is right now, as a fee-for-service, pay-for-volume program, is unsustainable, and certainly unsustainable at the point, as you suggest, that we have a looming influx of baby boomers. Mm-hmm. I think there's a very dramatic difference of approaches between the Republican plan, which shifts those costs onto seniors. It doesn't really lower costs. It just says you will pay 61% of your own health care up to 70%, a direct opposite of what
I would argue
that
that implementing the system would lower costs. And kind of the proof in the pudding in that was Medicare Part D. It's one of the programs, I think it's 40% under estimates performing because of competition within health plans for people's business. But so I would argue it does lower costs, but go ahead.
Well, I just wanted to say that that is one vision of the system, that you shift those costs to private insurers and somehow achieve something along the way.
The differences are so great. Matter of fact, in 30 years, the entire federal budget is going to be Medicare, Medicaid, and Social Security.
If nothing changes.
If nothing, so the differences are so great. So just saying we're going to cut back on reimbursements or create efficiencies, I don't see where you make that difference. That's my question.
Well, I think that
without
again,
completely reforming the system.
I think we do need a complete reform of the system, and I think the Republican budget chooses to do that with beneficiaries and just shift costs of who pays what.
Instead of shifting it to my
Affordable
17-year-old who's going to pay it for the rest of her life.
We need to look at the underlying health care costs, not just for Medicare, but it affects every private employer, it affects everybody who goes to the hospital, it affects every doctor, and the kinds of underlying health care shifts. And let me give you another example, Congressman, if I may, that we have finally started down the road of competitive bidding, a market strategy for durable medical equipment. It was started in 2003, pulled back in 2008, restarted this year in the test market where it's implemented. There's a 34% decrease in durable medical equipment without any jeopardizing of benefits. Those
more efficient. I
samples
just don't see where
throughout
I'm lost my time, but where that level of savings required to make it work and sustainable can be just come from efficiencies alone.
Chair, thanks, gentlemen, and recognize gentlelady from Tennessee, Ms. Blackburn, for 5 minutes.
Thank you, Madam Secretary, for your patience, and 3 of us are going to try to share the balance of your time and get our questions in. I would remind my colleagues, one of my colleagues from Illinois was making comments about what Medicare would be called going forward. I would remind my colleagues it was Obamacare or PPACA, whatever we want to call it, that cut $575 billion out of Medicare. It was a conscious decision to make those cuts. I would also remind my colleagues that Medicare is a trust fund, and the federal government has had first right of refusal on the paychecks of the workers of this country. And so therefore, making that kind of cut, I think is a breach of what has been promised to those enrollees. Madam Secretary, I looked at some of your comments from the Budget Committee yesterday, and I feel like we're kind of doing a session of kick the can. And you know as well as I do that as we have been with you time and again on these hearings, we have looked at access to affordable care and have tried to get some definitions from you. And IPAB is one of those that we are very concerned about how it is going to restrict or affect access to health care and what IPAB is going to end up doing. We know that supposedly some of the 15 experts come into IPAB are supposed to be pharmacoeconomics, health economists, insurers, and actuaries. We know that the president he has an initiative to achieve savings. So if they are not there to achieve savings, what are they there for?
They're there, Congresswoman, to recommend to Congress ways that Medicare can be solvent on into the future.
So you see it strictly as a solvency issue?
That's their direction.
That is their direction. Okay.
They are only triggered when independent actuary.
Let me ask you another question then, because we know the GAO is supposed to do a study by January 1st, 2015 on access, affordability, and quality. This is of IPAB. And then Kaiser Foundation recently noted that, and I'm quoting what they're saying, IPAB would be required to continue to make annual recommendations to further constrain payments if the CMS actuary determined that Medicare spending exceeded targets, even if evidence of access or quality concerns surfaced. And I'm quoting Kaiser Foundation. So how do you reconcile the statements made by the administration that IPAB will not impact access, affordability, and quality with the statements made by the Kaiser Family Foundation that IPAB is required to continue cutting, even if evidence of quality of access problems arise?
Congresswoman, I am not familiar with that Kaiser quote, but as you know,
Well, in the interest of time, then, if you're not familiar with it, would
I'm
you
not
submit
familiar
in
with
writing?
what Kaiser said. I'm familiar with the law, and I'm familiar with the way it works, and I'm familiar with the fact that what they are directed to do is when the independent actuary, on a yearly basis, which he does year in and year out, recommends a target goal for spending, assuming that Congress ignores that, doesn't act, they are directed to recommend ways to meet that spending target to Congress. Again, if Congress does not act, chooses to ignore
well,
it,
let me
chooses
reclaim my
not
time
to change
so
it,
that I can
then
yield
those
to
cuts
Mr.
go into
Shimkus. But I would also like to highlight that I am still waiting for a response from you on addressing waste, fraud, and abuse from the last hearing. And with that, I yield to Mr. Shimkus.
Thank you. Thank you, Madam Secretary. Welcome. And we're going to try to get you out here. This is our last couple questions. We're not going to match our greatest hits of the last time, so I'm not intent to do that. But the 2024 time frame for the expansion of the solvency of Medicare, is that based upon the 2024 expansion of the Medicare Trust Fund is based upon the
expansion or
the solvency?
The
solvency is based upon the $575 billion cut in Medicare. Is that correct? For the most part.
It's based on projecting what the trends are right now on into the future.
And based upon the double counting that we talked about last time. And I would just ask, your individual health insurance policy, do you have under the Federal Employees Health Benefit Plan?
I do.
And in the D.C. area, there's probably around 42 different choices for health insurance policies. I mean, in St. Louis, St. Louis area is 21. I think D.C. is almost double that amount. It's operated by OPM. They negotiate it. We have a premium support plan that you are a participant of and that I'm a participant of.
And the federal government pays about 70% of the cost.
All the premium support plan is
and it rises with the
a
cost
negotiated contractual relationship with private insurance to provide insurance just like you receive and just like we receive. So it is the same plan. So the voucher debate is not correct.
Well,
it's the same plan that you have, and I yield my time to Dr. Murphy.
Thank you. I'm just trying to find out some answers here. And if you don't have the information for this, could you please get back to me? One is an estimate of how much you think working on fraud issues will save Medicare overall, maybe in 1 or 5 or 10 years. Two is you're working on a number of issues about quality improvement. You did mention the issue about infections. There's been bills we've moved through this committee, a bill that I wrote to ask for transparency on infection reporting. I understand from speaking with the head of the Center for Disease Management that it's been about 27,000 lives have been saved by having the transparency, and I appreciate everybody who worked on that. If you could get us some accurate numbers of how much money that will save, too, over time, I'd appreciate that, too. So you have fraud, improvement of quality, and there's a number of issues there. Another option to reduce Medicare costs is the ongoing issue we have of reducing payments, which is the SGR, et cetera. And also means testing is being kicked around, too. But I do want to ask this, and tie in with some other issues. Medicare Part D, the actual part that's a donut hole, again, I don't expect you to know these numbers, but there's a percentage of seniors that never really they never got to that level because they never needed that much prescriptions. Do you have information on what percentage of seniors that was or how many that was who, in their spending for prescription drugs, never got there?
I know that about 8 million hit it. I don't know how many enrollees we have. I don't know how many are enrolled, but I can get you that number.
Let me lay out, because I don't want to play games, and I'm sure you don't like them either. I'm just trying to find this out. In terms of the number of seniors who actually had a donut hole problem, some never purchased a plan but never hit that level. Some did purchase a donut hole coverage plan and helped them through that next level. And some did not have coverage, and those are the ones we all share a concern about. So what I'm trying to find out as we're looking at honest numbers on this is what was the difference in the impact upon cost and quality of care. You're probably familiar with the study that came out that said about 50 to 75% of people who were prescribed medication
do not take it correctly. Either they never fill the prescription, they don't take it, they mix it with other drugs, and that leads to returns to physicians' offices, rehospitalizations, extended hospital visits, and emergency room visits. In the context of this, as we really try and look at honest quality, and I get real tired of this Republican-Democrat battle, I just want to talk about patients here. The issue is, if we get down to the concrete levels of this, what does it really save if we focus on how we can do such things as disease management and care management? As you know, right now, that's not paid for. And that's a big frustration for me, that someone who have a chronic illness, such as diabetes or cancer or heart disease, if they're not helped through this, and physicians aren't paid for this, so we don't pay a nurse to make the call and monitor this, it's a serious cost problem. And I hope that's something as we get through this, you can help us with some real numbers. I don't know if the IPAB board's authorized to work on these things. I tend to not think so, but correct me if I'm wrong. I would deeply appreciate further discussions with you on this outside of this artificial setting here, and to work further on this.
Well, I would very much appreciate that. We can get you some numbers. I'm not sure, since Medigap plans are sold at the state level and some cover additional prescription drugs, but a lot don't, how accurate I can, but we'll get you the donut hole numbers as much as we can. And we would love to work with you on coordinated care strategies, particularly for the chronically ill. I think that is an enormous opportunity for better care delivery at significantly lower costs.
Thank you. And I might add my closing part here is that I know that a lot of private plans end up paying these out of pocket now, where they will cover heart disease and diabetes. And I want to make sure we don't leave this hearing saying that everything the government does is bad and everything private insurance do is bad. I think there's a lot of mistakes on both. But I would hope we would not get into that finger-pointing and blame game, but instead say, let's look at how we can use disease management. And I want to hear how this is going to be done better. Thank you. I yield back.
Thank you.
Chair, thanks, gentlemen. Madam Secretary, we will submit questions for the record and ask that you please respond promptly to those. You've been very generous with your time. Thank you for your testimony. We will take a 5-minute break as we set up the third panel.